apart from me, I'll put myself on when we go through.
Okay, brilliant. Okay, let's go. Okay, good morning everyone, and thank you very much for joining this webinar. My name's Rosie Benneyworth. I'm the Chief Inspector of Primary Medical Services and Integrated Care at the CQC, and today we want to talk to you about our new transitional approach and our future strategy. So if we could go on to the next slide, please, Steph. So firstly, I just want to introduce the webinar team that we've got here. During the course of this webinar, please do ask questions through the chat, and the webinar team will be picking up some of those questions as we go through, but we will also be having some question breaks during the time as well. We want this to be a really productive hour. We know on Teams, we use Teams a lot at the CQC, but we know sometimes the technology doesn't always work, so bear with us if there's any glitches, but we will do our best to stick to time. We know you're all busy people, so we want to be use this time as wisely as possible. Just for your information, this is going to be recorded and we will be putting this on our YouTube page, and this is very freely available for you to share with colleagues so that they can have a look and see what we've been talking about today. So just onto the next slide, just to give you an idea of what we will be covering today. Our main focus of today is going to be our transitional approach and our strategy. And as I said, there will be plenty of time for questions as we go through. So moving on to the next slide, I just wanted to start by talking about our purpose and just reminding people about our purpose of making sure health and social care services provide people with safe, effective, compassionate, high quality care, and also importantly that we encourage services to improve. And I think it's just important to say that our purpose has not changed at all, and if anything, during the course of the pandemic it's become apparent that our purpose is even more important than ever. And during the next few years, as we go into our new strategy and our developments that are happening, this is something we will always come back to as to why we're here and what we're doing. And our teams across the CQC are absolutely passionate about delivering on their purpose. So if we could go to the next slide. So we know that before COVID, there was a huge amount of change happening across the health and care landscape. We know that there was many new models of care developing, primary care networks were developing, technology was being used in different ways, and integrated care systems were developing, and that was offering different ways of working. We've seen huge acceleration during the pandemic, and in primary care, for example, the use of technology, the work that has happened at primary care network level, we've seen massive changes, and we know that in order to deliver our purpose, we're going to need to change as well. We want to really enable those changes. We know that things can't stand still for the benefit of patient care. We know things have to move forward. There has to be innovation, there has to be changes, and we want to make sure that we're an enabler to that and not a barrier in any way. We know that the pandemic really amplified a lot of what we already knew, and that actually we need to change to be able to keep people safe during this and deliver on the purpose. And we know that actually to be able to deliver on our purpose, we want to change the way we regulate, so it's simple, so it's based on really strong, open relationships with providers, and we want to be more effective, and we want to focus our actions on the areas that can have the biggest impact on people's experience of care. So if we could move to the next slide. We started transforming the way we worked back last year, and there's a timeline that's going to be coming up now. And as I said, COVID pandemic has, as anything, accelerated our work around what we'd already were planning. We're now in phase 3 of our work, and we're going to be rolling out a transitional approach, which I'll talk to in a moment. Our strategy is being developed. We're testing out our ideas for strategy, and this webinar is part of that work, and we're planning to publish our new strategy in May of next year, and we want to be ready to go with implementing that new strategy from May. So we'll talk a little bit more about that as we go forward. So if I could just move on to the next slide, please, Steph, and talk about our new transitional regulatory approach. But before I go on to that, I just want to take this opportunity to thank you all for all the hard work you've been doing over the last few months during the pandemic. We are really aware of the huge challenges and pressures that all parts of the health and care system are facing at the moment. We work with a large number of GPs and providers right across the country who tell us, who give us that information as to what's happening, and we're monitoring on a very regular basis what's happening in all of the different areas and the impact that it's having on the different parts of the health and care system. So thank you for all you're doing, and we are, just to reassure the audience here, that we are really aware of that, and we are very sensitive to all of those pressures in everything we're doing. So just to recap, and next slide please, Steph, just to recap on where we've got to now. So as you know, in March we stopped our routine inspections, but we didn't stop inspecting during that period of time. We continued to monitor providers and we continued to regulate, even though we weren't doing our routine inspections. And we continued to respond to concerns raised, and we have undertaken some inspections over the course of the last few months as a result of that, where we've come across concerning information or risks that we feel we need to go and have a look at. We wanted, though, to make sure that we were offering as much support to the system as possible during this period of time, and we developed an emergency support framework that we followed during the first wave of the pandemic. And this really was about using and sharing information to target support where it was needed most, having those open conversations, capturing innovations, sharing those, and taking any action that we needed to keep people safe. We also used that opportunity to help signpost people to information. We raised risks both at a regional and a national level of things that we were hearing about, and that information we also fed through to many of our colleagues in places like the Department of Health and Social Care or NHS England. So there was a variety of information that we used to help support the kind of national effort and the regional and local effort in terms of the pandemic work. We're now moving to our transitional regulatory approach, and this will replace the emergency support framework, and our aim with this is to really target our regulatory activity as effectively as we possibly can. So if we could go to the next slide. So as I was saying earlier, we are responding to as sensitively as we can to the changing circumstances and the rapidly changing environment that we're all working in, whilst we're still continuing to put people who use services at the centre of everything we do. Our transitional regulatory approach brings together some existing methodologies with our learning from our COVID-19 response. Our overarching aim is to continually monitor risk in a service and respond to changes with the right regulatory approach. This is a transitional approach. A number of aspects of this approach will help provide some learning into how we regulate and how we develop in the future. And we're also, as well as looking at learning about this approach, this will also help inform the direction of travel of the organisation and where we're going from 21 onwards. So if we could go on to the next slide, I just want to spend some time talking about how we're going to regulate during the next phase of the pandemic. So we will regulate. We started rolling out our transitional approach at the beginning of October. We started in adult social care and also our dental providers. We've started rolling out in all hospital trusts from the 12th of October, and from the 19th of October we're rolling out our new methodology in general practice, independent doctors, slimming clinics, urgent care and out of hours. All of the remaining services that we regulate that I haven't covered there will happen in the next few weeks. And the components of our approach are firstly a strengthened approach to monitoring, a clear focus based on our existing key lines of inquiry, and these are all published on our website and available for everyone to see, and these will enable us to continually monitor risk in a service. We then will continue to inspect, but this will be on a much more targeted and focused basis, and this will be where we have concerns. I will say this several times during this presentation, but we will not return to a routine programme of inspections that are frequency based. I know there's been a lot of chatter in the media and various other things, the kind of trade press, but I just want to reiterate that we're not returning to routine inspections. This will be much more targeted at areas of concern, areas of risk. We want to hear your feedback about the changes we're making. We will continue to adapt our regulatory approach. We want to remain responsive as the situation changes. And we want to continue to learn, hear feedback, improve what we're doing, and then and change as appropriate so we can deliver on our purpose. So if we could go into the next slide, please, Steph. I just want to spend a little bit of time talking about monitoring. And the way we monitor services is being developed through engagement with lots of stakeholders, lots of people who work in services, lots of the public. And as I said, this approach is being developed for all of the services we regulate right across social care and health, be it NHS services, independent services of all shapes and sizes. In general practice, we've been working very closely with the BMA and RCGP, and we meet them weekly, and we meet regularly with all of our other key stakeholders, and all of that information is being used to develop our approach. So our monitoring will have key areas of focus based on existing key lines of inquiry, specifically targeting safety, people's access to services and leadership, but we will continue to build in other areas of focus. Using our approach, our inspectors will monitor and review information from all available sources, collecting further information where necessary. The main way we'll gather information from providers is through conversations we'll have with them when working through the questions in the transitional methodology. Inspectors will not routinely ask for additional information or evidence or request all of the information supplied in the examples. We want to keep this as proportionate as possible given the pressures, and we want to make sure this is as targeted as possible. Inspectors will apply professional judgment to identify the information they need to sufficiently assess the risk level of each key line of inquiry. And these calls, which some providers will have, will take about an hour, and we don't anticipate them to be any longer, and they will be done off-site. They will be calls in a similar way for those experienced an annual regulatory review type call. The inspectors will also gather information from people who use services and local groups, and we're testing how we can improve obtaining this information. The experiences of people who use services, their families and their carers are central to this approach, and also as our future direction as an organisation. To promote this, we've launched a year-long campaign with Health Watch England, the voluntary sector partners and others to encourage their people to share their experience through our Give Feedback on Care service, and anyone on this call can also use that that service for any of the services they're either working in or using as a patient or member of their families are using. We're going to also use a range of other information sources which will help inform our monitoring. This includes the work we're doing as part of the provider collaboration reviews, and also information gathered through our routine ongoing monitoring. And we work closely with bodies such as clinical commissioning groups and other NHS England and other bodies to help us get intelligence where needed. As well as the information on our individual system and services, we're also going to use information that we learn about local systems, building on the work around the provider collaboration reviews to understand where there are barriers to good care and understand how we can target this activity to help break these down. I know, for example, that many GPs have said that there is an impact, for example, about the impact of waiting lists, impact of some services not being available as a result of the pandemic. And we want to look and make sure that everyone is getting the care that they need appropriately, and look at that right across the system, and do what we can as a regulator to improve where needed. Our monitoring activity helps to prioritise the services where there is a greater level of risks, and then will help to identify what a proportionate response might be. Our inspection teams will always have the option to act quickly and use their own judgment where we get other sources of information that indicate greater risk. And I'm sure people on this call are aware we get a large number of information from people, from whistleblowers across from outside of the organisation, that we act on from any kind of concerns raised or safeguarding concerns, and our inspectors absolutely will use their professional judgment if they have concerns that they need to act on quickly. So if we could move to the next area, and I just want to talk a little bit about inspection. So just to reiterate, and I know that I've said this before, we'll not be returning to business as usual. We're not returning to our fixed frequency-based rules on inspection. We are very much focusing on risk, and we're clear that our focus is absolutely on services where we have concerns about care, and we will take appropriate action to protect people where necessary. We are aware of the pressures on providers, and we are taking that into consideration at every point. And we want to strike a balance between making sure that we hear people's experiences of care and accurately assessing quality while minimising the risk of spread of infection and not adding unnecessary pressure on the health and care system. Where we do have to carry out on-site inspections, our action will be targeted and it will be driven by the information we hold on a service, focusing on areas we can't collect information in other ways, or on services where we will need to visit more, such as secure settings, which is not such an issue in primary care settings. On-site inspections are a valuable tool in some cases, and we will continue to use them, but continue to use them proportionately. Where we have information that people are not getting good care, sometimes a visit is the way of really understanding what's going on in that service. So if we could move on to the next slide, please. I just wanted to talk about some of the work we're doing to pilot new ways of our working, and there may be people on the call who've experienced this. So we are piloting new ways of working in general practice, and this is also being replicated in some other parts of the organisation, like in our adult social care teams. And we're looking at how we can explore new ways of gathering evidence without actually having to be on site. But we're doing this with the explicit consent of providers. There's nothing happening behind the scenes that you don't know about. If we're going to be doing this, we'll have the conversation with you and make sure that you're happy for us to be doing this type of approach. So our general practice inspection, let me start again. Our general practice focused inspection pilot is designed specifically to help us respond to risk. We're going to carry out initially in about 30 services, and this pilot is evaluating how developments in digital technologies and working away from offices and locations can be part of the regulatory approach for the benefit of providers, the public and the CQC. It's going to test how we gather information, including how we can directly access evidence such as clinical records, and just to reassure people on this call, we will be doing that with the practice's consent and where appropriate. We're not going to be spending time looking at clinical records unless everyone is aware why we're doing that and what concerns we have. Upon completion of the pilot inspection activity, we will publish a short inspection report setting out the work that was carried out as part of this pilot. And this is one way we're trying to test a new approach to minimise our impact on providers and to look at how we can get the best approach to deliver on making sure that services for people are safe. So moving on to the next slide, I just wanted to touch on rating, because we know from feedback we've had from the public that our ratings and information about our assessments are vital for the public in a way that they can view the quality of the service that they're getting. What's going to happen with the transitional monitoring approach is that after we've reviewed the monitoring information and the streamlined set of CLOEs, the key lines of inquiries, we'll make a judgment. If we're confident at that stage that our review indicates a low level of risk and there aren't any risks to the people who use services that we can identify, then we will take no further action and we will let providers know that is the outcome. We're anticipating that the majority of people in whom we have that call, this will be the outcome. We're hoping that for the majority of providers, we will have a call, we will monitor the information, and the outcome will be that no further action is taken. With time, our plan is to publish a short statement on the services page on our website so that people who are using the services know what is happening. We want to be very transparent with the public who use services and everyone who involved, so people know what we've found. We're also going to share a summary of that directly with the provider. Before we do this, we want to work with people who use services and yourselves to make sure that what we do works for everyone. So that's an ongoing piece of work. Where the outcome of our monitoring activity leads to us inspecting a service, and as I said, we suspect this will be the minority of these assessments, we will use our existing inspection methodologies and will adapt these to work with the environment we're in. This means that across all of the health and care sectors we regulate, we can still look at any or all of the key lines of inquiry on inspections to ensure that people are receiving safe, high quality care. Our inspections will be more targeted and focused around areas of risk, so we may not cover all the 5 key questions and our key lines of inquiry. So as a result of that, our inspections may not always lead to a change in rating for a service. Our ability to re-rate our services is limited at the moment by our published methodologies, and that is something we're working on as we go forward. We may be able to re-rate a service in limited numbers of cases, but this will vary in practice, and it will vary between the sectors that we regulate, and we will keep you updated around this as we work through it through our blogs and our regular bulletins and our updated guidance, so you know what to expect. I think it is an important area. The public want to know, they like to know what the ratings are. It is something we are working through and we will continue to update you about. Okay, so that's the first part, and before we move into the strategy, what I'd like to do now is just break, because you probably had enough of me talking for a minute, just to hear some of your questions and see if we can answer some of them.
Thanks, Rosie. We've had some great questions on the chat. Thanks for everyone for submitting those, and we'll try to get through as many of them as possible on this call. But if we don't get a chance to answer your question, don't worry. These will all get fed into our work developing our transitional approach and strategy going forward. One of our most popular questions is around the issue of access in general practice, Rosie. And I think we all know there's been a lot of public conversation about access, and we've seen some great work in the sector to make sure people still have access to general practice. But I think there's a question about what's our role in talking about the work the sector's done, and how the public and patients who experience in access. And did you want to say something about that?
Yeah, certainly. Thanks, Sam. And this is a really important area. So if I start, and Vicky Wells, our Deputy Chief Inspector, may want to come in, who leads on general practice and is doing some work around this. Firstly, we know that practices have made tremendous efforts to change the way that they operate, to make sure they meet the needs of the public. And we've heard some fantastic stories right across the country of the work that people have done to enable good access for the population that use them. Access is really important for so many reasons. We know, and I'm sure everyone shares my concerns on this call about the people who for whatever reason have chosen not to access services or have not been able to access services, and they're two different things. For things like cancer or other conditions, that means that their outcomes may not, as a result, be as good. And we know that quite a lot of this has been driven by public behaviour and by people either being worried about accessing services or choosing not to because they haven't wanted to bother the NHS and have felt it's not appropriate. So I think the first thing I would like to say is that we all need to be doing our part to encourage the public to seek access when they have worrying symptoms or worrying conditions. I think, I'm sure many of us have seen the kind of modelling around cancer and delayed diagnosis, and it's hugely concerning. I think the second thing I'd say is that I think that one of the things, we are doing some work around this because we do want to understand what is happening in access, and we do want to pick up all of the good practice that people have put in place. We know that there has been a lot of changes and practices have undertaken a lot of innovation around access, and we want to pick that up and we want to share that good practice. So we will be doing some work over the coming 2 or 3 months, and we want to understand it through our transitional methodology to really be able to talk about all of that great work that's happened and all of the good things that have happened. And in particular, I think one of the things we've heard from some of the public is that actually sometimes they don't understand the changes that have happened in practices, and I think that sometimes this is leading to a difference in perception about what's available and what the public understand that they can expect. And I think those we particularly want to focus and find those practices that have really engaged with the people who use their services and communicated in innovative ways, so that actually the public really understand how to access the services and the services, how the services have changed within those practices. We have heard in a minority, a small number of cases where the public haven't been able to access services. For example, we've heard about practices that have said if you're between 15 and 50, you're not allowed a face-to-face appointment under any circumstances. And clearly that is really unacceptable, and we are following up any cases that we hear where the public are not getting appropriate access. And I think there's two aspects. One is, can people get an appointment, and do people know how to get in touch with the practice and how to access those appointments? I think the second thing is, are those appointments that are being offered, are they appropriate to meet the people's needs of the population that use the practice. And I think we're all on a steep learning curve about what's appropriate for digital and what's not. And I think that's something, you know, as a system, we probably need to understand more as we go forward, and we need to understand, you know, what safe look like, and what does appropriate use of digital look like, and find that balance between digital, which is a really effective mechanism of consulting with patient for some patients, and face-to-face, which is appropriate for some other patients. So I think it's something we are doing some work on to understand. We do want to support practices, and we do want to share that best practice. But you know, for people on the call, I think it is worth considering how are you engaging with people, how are you communicating with people around the changes that you've made, and can you share those great ideas with us if you've been doing something in this area? We are going to be putting a survey up to capture those good ideas and share them, so that we can help support sharing that learning. So it would be great to hear from you around that. Vicky, is there anything you want to add?
No, I think, Rosie, you've covered most things. I think the point around communication and accessibility of information for people using services is really critical with this, because what we are finding is that often two practices are offering really good access to patients are communicating this in different ways, so people are experiencing that very differently, and could believe that a practice has its doors shut, when actually that they're offering a perfectly good access to appointments once people actually get through the door. So I think sort of local communication is really important. Information on practice websites is important, and I don't think you referred to it, Rosie, but we're also accessing the Local Health Watch national publications, a great resource for providers to actually access that information, to be able to understand locally what people believe that they are experiencing, which may be different to what you're actually offering.
Yeah,
that's great.
Thanks
Vicky. Both. We've also had a few questions just wanting a bit more information about what might trigger an inspection during our transitional approach, and Vicky and Manny have both posted some answers in the chat, but I wondered if we wanted to give a bit more information about the kind of things that might mean we end up going into a practice and inspecting face to face.
Yeah, certainly. So if I start, and then Vicky and Manny, please chip in. So we want, as I said earlier, we want to make sure that this is a proportionate response. If we get, you know, a few queries in from people saying, oh, I don't know, very minor things, then we will look at that and we will take some professional judgment. If we get a whistleblower who phones us and says, and we get quite a few people who work in services phoning up about the services they work in, who says, I'm really concerned about something significant. There's you know, all sorts of things. We hear about bullying and harassment, we hear about sexual assault, we hear about people who are not getting the care they need. If there's serious concerns like that, then we will follow them up. Or if there's concerns about safeguarding, that people are not being safeguarded, if there's concerns about human rights not being considered, we will follow that up. Sometimes we get contacted by coroners, we get information about deaths that have occurred, serious things like that. We will absolutely be following up. Then I think so that's an absolute. If there's kind of a series of kind of lesser concerns, but they all add up to something that makes us think, you know, this is not adding up to a great picture, and we can't get assurance from that provider from what they tell us over the phone, then again we will inspect and follow up. So Vicky, do you want to add to that? No,
I think you've covered it, Rosie. We did see during the pandemic, we we had a slight decrease initially in the pandemic of people coming and sharing their experience with us, which has now started to increase again, and that's in terms of people coming to us, so people using services, but also whistleblowers coming to us. And I just want to emphasise that we will only inspect if we need to inspect. So our first option is to always explore all of the information that we hold, have conversations with partners and external stakeholders and with the providers themselves. So we are only inspecting at the moment in response to risk.
Yeah, and just to add to that as well, our inspectors have very clear guidance around this, and they don't make those decisions about inspection individually. They work through their management teams, and so there will be a team approach to deciding who gets inspected. It's not sitting with one individual because we want to make sure that we're consistent in our decision making throughout.
Thanks both. We've also had a few comments just just reflecting on the pressures the system is under at the moment and the pressures providers are under, and I wonder if we want to reflect on you know, why we think the transitional approach is the right approach at the moment, and where we are offering support where it's needed and what that might look like for providers.
Yes, and we are aware that there is huge pressure at the moment. I think, you know, we're very cognizant we're in a global pandemic. We're very aware that demand on primary care is going up, and we're very aware that a lot of what's going to happen in the next few weeks and months is an unknown, and there's a huge amount of uncertainty. And we know that that's compounded not just with the kind of clinical care that's happening within providers, but it's compounded by the impact on of testing and impact on you know, people being off sick in practices. We're aware that actually this is having a massive impact on people's personal lives and mental health and everything else. So we are completely aware of that. I think it's fair to say however, the areas we've been following up during the pandemic are areas that actually have not, often the risk has not been related to the COVID pandemic. We have seen, sadly, areas where people are not working in roles where they're not supervised, and that's leading to risk to patients, and we've seen the direct impact of that. We've seen areas where you know, people are not, they're talking about 2-week wait referrals and then not making them over a period of 6 months. I mean, we're seeing some very shocking kind of clinical care. We've seen areas where you know, we've seen areas of sexual abuse, we've seen areas of patients, we've seen areas of deaths of patients as a result of poor care. So we are not talking about things that are, you know, mop heads and buckets here. We're talking about really serious aspects of clinical care that have a direct impact on patients, and they have been present despite COVID, not, you know, because of COVID, actually, in the experience that we've had over the last few months. And I think that is why we feel we need an approach that actually is proportionate, but we can't take our eye off the ball, because patients do deserve good quality care, and we know that the vast majority of practices are offering really good quality care, but we need to continue to monitor the situation. We also know that actually things can change very rapidly, and it can be due to a whole variety of factors that can impact on the quality of care of providers. So we can't just assume that all providers that were good will stay good, because we know, for example, in our evidence from last year, that 17% of good and outstanding practices, their quality of care deteriorated. So we do have to have a mechanism of monitoring. We want to make that as proportionate as possible. We want to have as minimal impact as we can on practices that are, you know, going ahead and doing well and doing the right things, but we do need to have a mechanism of picking up poor practice, and actually for the benefit of you know, general practice as a whole, the reputation that some of these very poor providers can lead to, and the damage that can cause more broadly is huge. And I think we'd all agree we want to see people being able to access good quality practice across the country.
Thanks, Rosie. Just conscious of time, I wonder if we want to move on to the strategy slides now, and then we'll be able to leave some more time at the end to pick up the rest of the questions.
Yes, certainly, Sam. So just to whiz through a final few slides, and if we could go to the next slide, I just wanted to talk about the new strategy that we're going to be implementing from May of next year. It's going to be out to consultation in January. We do want to hear your thoughts about it, but there are 4 key themes of this. One is around people, smart, one's safe, and one's improve. And we, as I've said before, we absolutely want to use this to change people's lives for the better. We want to really add value as a regulator to make sure that we're moving the dial on improving services for people who use them. So if we could go on to the next slide, if possible. And I just wanted to briefly talk about the people aspect. So we want to regulate through the eyes of people using services, and we also want to know that we want people to know that if they've taken the time to feedback on services, that we've listened, that we've acted on what they've told us. Sorry, the bin man's just turned up outside my door and is making lots of noise, so apologies if there's some background noise. They always turn at the wrong time. Secondly, I think inequalities are something that are a big focus for us. We have concerns, as I know many people do at the moment, about the widening inequalities gaps. We want to do everything we can as a regulator to address those inequalities, particularly about unwarranted variation and inequalities in health and care. And finally, just to mention on the slide, we know that the quality of care someone experiences is partly about what they experience in one provider, so what they experience in their general practice, but actually a lot of the quality of what someone experiences relates to how they move through between lots of different parts of the health and care system. We know people, particularly with long-term conditions, multiple long-term conditions, complex needs, they often are involved in lots of different services, and actually the quality of the care that they receive very much depends on how those providers work together. And I think for us it's absolutely imperative that people in local communities, providers in local communities right across the health and care system work together to really meet the needs of their local populations. And we think that that will also help look at inequalities as well. So moving on to the next question, just wanted to talk about our smart aspirations. So we've heard a lot from people over the years about how we work, and we want to address that. We heard that there's concerns about consistency in our ratings. We heard that sometimes ratings of a service can mask concerns in other areas, in smaller areas. We did get strong support for the use of inspection in our regulatory work, but we've had a clear message that this should be more targeted. So we're really developing proposals about how we plan to evolve our ratings programme to make sure they're up to date, meaningful, and they focus on what matters to people most. We want our inspections to be more targeted, and I've talked about that earlier. And I think the other thing is we want to make sure that we work effectively with other regulators. So we know that sometimes we ask for information, other regulators ask for the same information but in a slightly different way. We all kind of add to the workload in a practice or in another provider, and we want to make sure that we're working effectively and smartly with other regulators so that there isn't that duplication, that we're making it easier for us to collect information and share information digitally. So lots of work going on in that area as well. The third area is around safety. And I think, safety culture is really important for all of us. If we could move to the next slide, please, Steph. I think I was really shocked last year. I was at a patient safety event and shocked to hear that avoidable harm is still one of the top 10 killers in the world. There's been a lot of discussion about this over the last few years, but we still have a significant amount of avoidable harm across all of the services. And we need to really promote that culture where people can talk about things that go wrong, people can speak up about concerns, people can then use that information, learn from it, learn collectively, both within practices, within systems. How many times have people got together across a local area to say, actually, this person's care has gone horribly wrong, and actually it's not just about what happened in the GP, it's about what happened in out of hours and what happened in the in A&E department, and learn. So we put in place things that are going to improve that to prevent them happening again. And we really want to develop that patient safety culture and do everything we can to promote that through our role as a regulator, because we think it's really, really important. And just finally, the final area is around improvement. And we need to make sure that people have a consistent offer to help them improve. So we want the whole system to be continually improving, both within providers, but also right across those providers. And we want to make sure that the quality of care that people get continues to develop. We can't stand still with all of the changes around us, so providers need to continually work on what they're doing and continually improve, and we need to drive that culture that enables that improvement, that drives that professional curiosity as to, I wonder what the outcomes are for my patients who I'm doing this, and how can I do something to improve that. We also know there isn't a consistent offer at the moment for practices that are struggling. We're trying to address that with our partners. We're working closely with partners across the NHS England and NHS Improvement and the Royal College, because I'm keen that we actually, when practices are struggling, or even if they're starting to wobble and deteriorate, that actually they get help and support so that they can get some early help to really improve what they're doing, so patient care gets better. So those are our thoughts about our role, and we want to take a very active leadership role in driving that improvement across the system. So final couple of slides. Just in terms of what's going to happen next, so we're going to continue to develop what we're doing. We're going to consult on our strategy in 2021. Please do get involved, and we'll put up a link at the end with ways to get involved and give your feedback, as well as through this discussion. And in the future, as going on to the next slide, please, just to let you know, we are planning to publish the strategy in May, and we want to be in a place where we start straight away. This isn't going to be a document that sits on a shelf. Our strategy is going to be made into a reality, and we're going to be starting that from May onwards. But keep an eye on all our blogs, all of our bulletins, and we will be continually keeping you updated around that. So, Sam, I think we've got a couple of minutes for any final questions.
Yeah, definitely. Thanks, Rosie. So we've got a question here that's kind of reflecting on the great work primary care has done to kind of transform and innovate during COVID, and a bit of a challenge to us about whether we could do the same going forward, and I think in particular around how we collect information from providers.
Yes, really good question, and it's something we are looking at the moment in how we do this. In an ideal world, we'd be able to have the information without having any impact on providers, and we'd be able to gather information and work with other regulators as well. So that information we can get from various sources, so we can continue that monitoring in the background without having any impact. we are working on that. It is something that is high on our priority as part of our developments. We have changed our methodology very rapidly over the last few months. In fact, the transitional methodology is the second new methodology we've got in 6 months as a response to the pandemic. So we are working very hard behind the scenes to be able to adapt to the new challenges and to make sure that we're as proportionate as we can be with our new methodology. But a very good point. We are listening. We are trying our best to move that forward as quickly as possible. So thank you for the question.
Great, thanks, Rosie. I think there's also a couple of reflections about what CQC's role should be in celebrating success and outstanding practice in the sector. Maybe part of our improvement theme. Did you want to say a bit more about that?
Yes, and that's another question we're working through, and it'd be great to hear more about your thoughts, because actually in our traditional methodology, we have very much gone out to outstanding practices. We've been able to collect that information. Last year we did some podcasts about what we saw in outstanding practices, and we shared those widely and shared the really good innovations. And we heard a lot back from practices that were outstanding about, you know, how they felt the inspection process was positive and supported what they were doing, and lots of feedback around that. The feedback we've had from our stakeholders over the last few months is, given the circumstances, people are very keen that we focus on risk and concerns. And so that has been the focus of our transitional methodology. But I do think we do need to consider, as part of our improvement work, how we continue to recognise the really good and outstanding practice that is happening. And there is a lot of that across the country. You know, we ought to be very proud about what general practice does in this country, and very proud about the fact that the vast majority of practices are good and outstanding and delivering excellent care to their patients. So it is something we want to work on. There are ways we might collect that information through various thematic approaches. Please get involved in the provider collaboration reviews when they're happening in your area. We've been to 11 systems so far. We're going out to more systems. We want to collect the valuable role that primary care is playing in those different pathways. And just so you're aware that the next pathways, we looked at the care of over 65s between health and social care in the first 11. We're currently looking at urgent and emergency care. It's then cancer, mental health and learning disabilities, and we've published our state of care report, which has got the information about the first range of reviews, and we will continue to publish those that information, and it's all available on our website. But those are really capturing the important role of primary care in the wider system and the innovations that are happening. And some brilliant stuff we heard in the first round of primary care reviews. For example, you know, some great stuff about how local GPs, I think it was in Slough, for example, had worked with local faith groups to make sure the testing was available and appropriate to meet the kind of the requirements of the local population. So there's some great examples. Have a look at those. But it is something we do need to consider, given we're not going to be going back to our routine inspections. So thank you, Sam. Thank you for the question.
Thanks, Rosie. There's also a bit of a reflection in the chat about how we might need to be flexible in our approach in some areas going forward. So in particular, someone talks about focusing on safety, and how while one approach might be safe for a certain population group, it might not be safe for another. Do you want to talk a bit about how we might have that flexibility going forward?
Yes, it's a really good question as well, and we do need to find a way, and part of what we're looking at the moment is how do we develop our approach? If we're going to look at inequalities, how do we start to look at how we understand what's happening in one area that's similar to what's happening in another area, and the challenges that different populations might need, have to meet the needs of their population. So I think some of that is through our more sophisticated use of data that we're anticipating through our strategy developments, is how can we then use data really to drive our understanding, and our understanding, you know, starting to then be able to compare areas where there's similar demographic profiles, areas with similar challenges. We're not there yet, but that's where we would like to get to. And part of our work around looking at how people move through the different systems, it will look, and the provider collaboration reviews have started to explore this, will look at actually how do we understand what those population needs are, how do we understand how practices are working with their local communities, how the voluntary sector are involved, how we're working with, how trusts are working with primary care, all of those type of things, because I think all of those, it's going to be a necessity going forward. If we're really going to look at tackling inequalities as a whole health and care system, then actually we need to make sure that there's that really good understanding by all parts of the health and care system about what their population needs and how they're adapting to do that. So we're testing approaches around that. We're trying to be as flexible as we can be, and we will continue to develop that as we go forward.
Great, thanks, Rosie. We also have a question that comes up quite frequently, and it's about the consistency of our approach. Is there something we want to say about how we might want to be consistent in the future and work we're doing to ensure that?
Yeah, certainly, and this has been something we've been working on for some time, and have had a whole range of measures with our traditional approach in terms of how we make ourselves more consistent, which involves regular national panels, which have a variety of senior members sitting on of the CQC sitting on them, retrospective panels where we look back at inspections that have happened to make sure they're consistent, very consistent guidance to inspectors, regular training, all of those type of things. So that's what we've been doing so far, and whilst there's still a lot we can do in that area, there has been improvement over the last 2 or 3 years in that area. But this is a real opportunity with the new transitional methodology, with our use of technology. We've got a whole series of work underpinning the new transitional methodology, which involves new IT platforms, which will enable us to have a much better consistent approach enabled by technology to do that. So that's in process, and it is absolutely part of the thinking as we go into our new strategy. I think it's fair to say we have to always balance consistency with making sure that we don't want our inspectors to be tick box people with clipboards. We absolutely value their professional judgment, and we want to make sure that they are empowered to use their professional judgment in line with our guidance and our kind of quality assurance processes that we have many of to look at consistency. So is that all the questions, Sam? I'm just conscious of time. Shall we just finally just talk about how people can get involved?
That's great, Rosie.
That'd be all right.
Just to quickly mention, because a few people have asked about where they can find more information about our transitional approach, just to say there is quite a lot on our website, and we'll share the link with attendees after we finish today.
Fantastic, thank you. So if Steph, you could move just to the next slide. Here's a variety of ways you can get involved. We really do want to hear from you. So there's a Citizen Lab platform where you can share all sorts of thoughts and ideas on that. We do our regular bulletin, which you should all get. If for any reason you're not getting that, please let us know. We send it out to all providers, and likewise we include blogs which give an update of what we're doing with that. We have a Twitter account, and we also have a series of podcasts, so have a look at all of those. And like I said earlier, the other option is if you want feedback on any service that you or your family are using, good or bad, or you know, any feedback at all, please use our Give Feedback on Care, which also is an opportunity for you to feedback to us about the services around you or that you're involved in. So I think that's all for today, other than to say a massive thank you to you all for joining me today. Thank you for everything you're doing again, and good luck over the next few weeks. And I hope that you all have a good day and a good rest of the week. So thank you ever so much.